task in the coming minutes is to talk about the use of sulfonylureas during Ramadan. Are they safe? And in fact, this is a very interesting topic. So this is the outline of my talk. I'll talk about a consensus report on issues, general use of issues outside Ramadan, and then focus on the studies in Ramadan. So I wish that all of us reach the holy month of Ramadan, the month of mercy and forgiveness. And it's a really a wonderful month that all Muslims and even some non-Muslims enjoy the fasting practices. This is the paper that I wanted to discuss, where experts from GCC countries met on several occasions and came up with a consensus on the use of sulfonylureas in the current practice of type 2 diabetes management. Are there differences? And this report has been published in a prestigious journal, Diabetes Therapies. So what this consensus, which has been endorsed by elite societies in the region, the Gulf Association for Endocrine Diabetes, the Saudi Diabetes Society, Emirates Diabetes Endocrine Society, and Bahrain Diabetes Society, what it says, or what it talks about, it talks briefly on the epidemiology on the use of diabetes in the world, and focusing on GCC, the diabetes control in GCC, mechanism of action of sulfonylureas, the long-term efficacy, end organ effects or benefits, cardiac and renal, and in particular weight gain. And there is a chapter in this consensus talking about the risk of hypoglycemia in Ramadan studies. Generally speaking, issues are still a group of the most effective medications to lower blood glucose and control patients with type 2 diabetes. And they are still commonly used as second-line agent for patients in low to middle income countries, but even in developed countries. And statistics has shown that in the United States, 41 to 45% of patients are still on sulfonylureas, and 31% in USA, and 41 to 45% of the patient in UK. So still widely practiced. And systematic reviews, which we know that they are on the top of evidence-based medicine criteria that we use, the top are systematic reviews, and there have been many of them on sulfonylureas, which proven that hypoglycemia, when adding these agents to metformin, is totally different between medications in the class of issues. So the elder generation, first, second generation, and third generation sulfonylureas like glibenclamide, glipizide, and glipizide have lots of hypoglycemia, which is not the same or typical of fourth generation, the newer generation sulfonylureas like Amaryl, which is glimepiride and gliclazide. But even comparing these latest generation sulfonylureas, speaking about glimepiride and gliclazide, although they reduce A1C at the same magnitude, minus 1.2, 0.3%, still there are differences in the rate of hypoglycemia between glimepiride and gliclazide MR in particular, with much lower hypoglycemia in studies looking at comparison, head-to-head comparison of these trials. Cardiac safety has been a debatable issue with sulfonylureas, with many people saying that probably they increase or decrease pre-ischemic conditioning, post-cardiac insults, and predispose to cardiac disease, while major big trials like ADVANCE and ADVANCE-ON has confirmed their safety of gliclazide MR on the cardiovascular system. And recently, majority of us know two studies, two big trials. One of them is the TOSCA-IT, looking at the incidence of cardiovascular events, comparing bioglitazone versus sulfonylureas. And the finding of this trial that metformin plus bioglitazone and metformin plus sulfonylureas, there was no difference between bioglitazone and sulfonylureas on cardiovascular outcome. And the second big trial that I want to allude to is the Carolina trial, comparing glimepiride to linagliptin. And as has been shown in this study, there was no difference in 3-point MACE between the two medications. Glimepiride did not increase cardiac mortality compared to DPP-4 inhibitor, linagliptin in this case. Analysis by Stimson, cardiovascular safety, 18 studies, 167,000 patients, and those glycoside MR stands out, shining on the compared to other sulfonylureas, like on all-cause mortality and CVD, cardiovascular disease related mortality. So clearly there are studies, many of them, I just mentioned few of them, making a difference or differentiating between newer generation sulfonylureas and older generations like glipizide and glibenclamide in particular. And this is probably related to the mechanism of action, because issues differ in their affinities for sulfonylureas receptors in different tissues. So glycoside has high affinity for and reversible binding to sulfonylurea receptor 1 on beta cells, and does not bind to these receptors which are present on cardiac muscles or cardiac cells. We are blessed to have an International Alliance for Diabetes in Ramadan, and many of you have been part of this beautiful publication on Diabetes in Ramadan Practical Guidelines 2021, where Dar has gathered the evidence for Ramadan studies in one sort of document that was published in 2016, updated regularly, and now in 2021 we have these beautiful guidelines covering major areas, lots of areas in diabetes care, and one of them is diabetes management of diabetes type 2 when fasting Ramadan, and this is chapter 10 in the guidelines. The chapter lead was Professor Wasim Hanif, and the co-authors Muhammad Hassanein Tariq Al-Had and Nazir Muhammad. And in this chapter, there are beautiful tables looking at all oral agents used in Ramadan, linking or collecting the studies that have been done on these various agents during the holy month. And the tables on sulfonylureas, just in brief summary, several studies has been done on sulfonylureas in Ramadan, and Aravind in 2011 and 2012 published these papers looking at various sulfonylureas, glibenclamide, glycoside, glimepiride, and looking at here the outcome of glycoside study in Aravind trial in 2011. Small number of patients, 32, 2.6% risk of hypoglycemia compared to glimepiride 5.1 and Dawanil 10.8 or glibenclamide 10.8%. In 2012, 22 patients, 870 patients compared to DPP-4 inhibitors, 1.8% risk of hypoglycemia. Overall, sitagliptin was having lower rate of hypoglycemia, but probably related to the more risk of hypoglycemia with the glimepiride and glibenclamide, while glycoside in particular had similar rates of hypoglycemia compared to sitagliptin. As-Sifri had published a beautiful paper, and then these are two papers, elder paper 1993 and 2002. These are looking at glibenclamide, the older sulfonylureas. But let's focus on a As-Sifri finding that has been published in clinical practice few years ago, and this study has been done in various countries in the region, in the Middle East and Far East, and the finding is that glibenclamide rate of hypoglycemia 19.7%, glimepiride 12.4%, but look at the comparison between sulfonylureas and sitagliptin, comparing glycoside MR in particular and sitagliptin, a similar rate of hypoglycemia with this particular sulfonylureas, indicating that these agents differ in their hypoglycemic potential. Muhammad Hassanein came up with the more recent trials in 2014 and then in 2020 Dar Ramadan trial. The 2014 trial was a double-blind randomized controlled trial looking at comparison of vildagliptin and glycoside, showed no clear difference between these two agents, 6% and 8.7% rates of hypoglycemia in these two agents, comparing them together. And then Dar Ramadan was a really nice study comprising 1,214 patients, various countries in the Islamic world, Egypt, Indonesia, Bangladesh, India, Malaysia, Kuwait, Saudi Arabia, and UAE. And this is the finding: symptomatic hypoglycemia. The figures of hypoglycemia were really low. This was an observational open label trial and real world study in Islamic countries. And glycoside MR has resulted in 2.2% symptomatic hypoglycemia, 1.6% confirmed hypoglycemia, 0.3% A1C reduction. No patient had severe hypoglycemia requiring assistance, and surprisingly, or actually not surprisingly, because this has been shown in other studies, weight reduction 0.5 kgs. Those who have a lower BMI tend to lose weight with glycoside MR rather than gaining weight, as what is believed with sulfonylureas. So all in all, this is a summary of the major trials on the use of sulfonylureas and the risk of hypoglycemia in Ramadan. SIFRI, number of patients, Middle Eastern countries, comparing issues with sitagliptin, Aravent, 870 patients, India, Malaysia, sitagliptin virus issue, and Hassanain Dar Ramadan in the Middle East, India, Southeastern Asian countries, glycoside MR observation trial, and all of them compared that probably, or there is a clear evidence that glycoside MR in particular is different from others. Again, this is a summary of the major 3 trials that looked at the issue, and all of them are consistent with their conclusion. The safety of issues is not uniform. Glycoside associated with lower hypoglycemic rate than other issues and similar or better rates than sitagliptin. So the lead author conclusion of chapter 10, looking at the agents to treat oral agents in the treatment of type 2 diabetes, and actually GLP-1 as well. The studies demonstrated, and this is their conclusion, that people with type 2 diabetes can continue to use modern issues such as glycoside MR, glycoside and glimepiride, and fast safely during Ramadan. The use of older drugs within this class, such as glibenclamide, should be avoided during Ramadan, and the use of these drugs should be individualized following clinician guidance and medication adjustment. In this part of this table, the use of sulfonylureas in Ramadan, it's recommended that you shift to newer agents, glycoside, glimepiride, where possible, and avoid glibenclamide during the fasting of Ramadan because of the clear evidence of higher rates of hypoglycemia. If it's taking daily, then you take that tablet at iftar time, and in patient with excellent, good glycemic control, probably you need to lower the dose because of the long time of action of glimepiride and glycoside MR. If it's the agent is an elder agent like regular glycoside or glimepiride, then the sahur dose, the iftar dose is not changed, full dose, but probably sahur dose may be reduced in patient, especially in patient with good glycemic control. So this is a graphic that has been put in the guidelines, 2021 guidelines. Once daily dosing, take it at iftar. Twice daily doses, iftar time is the same. Probably good control people reduce the dose at sahur time to avoid hypoglycemia during fasting. Try to shift to a newer generation. The second generation is used such as glycoside, MI, glimepiride, instead of older agents like glibenclamide. Cost is very essential, very important, and look at the difference of the cost of issues compared to DPP4, SGLT2, and GLP-1 receptor agonist minimum yearly dose. This is in the Kingdom of Saudi Arabia where I practice, looking at the minimum yearly cost, maximum cost, and an average 201 Saudi riyals and the cost per year using sulfonylureas. DPP4 inhibitors on average yearly cost 1,300, SGLT2 inhibitor 1,600, and GLP-1 receptor agonists are quite costly, 3,600 Saudi riyals average cost per year. So in summary, IDF DAR practical guidelines provide healthcare practitioners with background and practical information to help optimize care for patients with diabetes fasting Ramadan. Ramadan focused education is critical to the success of these guidelines, the follow-up of or the working on these guidance to treat our patients. Each patient is different. We need to individualize our treatment based on the patient sitting in front of us, and the medication type, dosage, and time may need to be modified Clearly, there are differences between issues, and that applies also to their use in the holy month of Ramadan. Thank you very much for your attention.